So the nerve impulses, they generate from the synapse. This is called synaptic transmission. You know, you have read in physiology. Synaptic transmission of the generation and transmission of the nerve impulses. The neurons, they generate an action potential like in your cardiac myocyte, and then they relate to the axons and they other nerves, then other nerves. This is called crosstalk. They ultimately they come to peripheral nerve and supply the muscle. So when I'm holding this pointer, that means now impulse has gone from here to there and it is informing my muscle to work. So ultimately the end part is a muscle, the reaction, the processing, and the reaction of the last part, that is muscle. And coming to another few important anatomical points here is you have two hemispheres, and each hemisphere is divided into 4 lobes. The 4 lobes are functionally different. They're functionally different, namely, you know, frontal, parietal, temporal, and occipital. Frontal, parietal, temporal, and occipital. 4 lobes on each side. And you have higher functions. The anterior part usually have an execution function, the doing thing, execution of function. And the posterior part is constructing or perception, constructing. Suppose I want to lift the pointer here. I have to think that it's in a fraction of a second. Suppose I want to show you something, I'll pick pen and go and write there. So before picking, my brain should occur to my brain that I have to pick up the red pen or I have to pick up the black pen. So that is the posterior part. Then when I'm writing, that the doing part, that execution part is conducted by the anterior part of the brain. So this is general rules, but they're all again well connected. There's no separate entity. They're all interrelated to each other. Each lobe has a separate function, as I told you, and each lobe. But there are some certain functions which are lateralized to one hemisphere, like it depends on your dominance. You know the dominance? I'm sure you know what is dominance? Cerebral dominance. Can you type? Dominance means one lobe, we call it dominant because the dominance of hemisphere also relates to the dominance of your hand. So if I'm a righty, if I'm a right-handed person, 90% of patients will have the dominance on the left side, left hemisphere dominance. And if I'm a left-hander, 50% of the time my dominance is on the right side. That is the physiological function. The dominance of the hand also goes with dominance of the hemisphere. Why is it important? Suppose there is a right-handed person. Dominance means wherever the language center is there. Language center is not bilateral. That's why all functions are bilateral, but there are some functions which are called lateralization. They are limited to one side only, one hemisphere only, like language. Language means reading, writing, listening, understanding, and speech. These are the components of language. Components. Language means not just the speech. So, whichever side hemisphere is having the speech center, the language center, that is called dominant hemisphere. I told you, when I'm a righty or a right-handed person, my dominant hemisphere is left. Therefore, suppose I have a right-sided hemiparesis, my speech will get affected because my speech center is here. I'm a right-handed. If I have a left hemisphere, because my right hemisphere is non-dominant, my speech is not affected. This is how, this is given in the history. If you talk to the patient, handedness, finding about the handedness is very important in some of the formats of clinical examination. They say name, age, sex, address, occupation, handedness. Some people include in this topographic details. So sometimes you can include this handedness in CNS examinations, up to you. Okay. So again, you come from top to bottom, the cortex. Cortex, that is a gray matter. It's the coverage of the entire brain is covered with the cortex, or thin layer of cortex, gray matter. The cortex is gray matter. It has got your motor cortex and sensory cortex and other cortex also. And when you come down deep, you have white matter. In white matter, you have so many nuclei, so many cells, so many basal ganglion, subcortical white matters. Then coming to brainstem. Brainstem is a very small thing. It's like a junction box. So all the fibers that are coming from the top will converge into a small, it is just 1 to 1.5 inch or 2 inch long. Brainstem is very small. This is a junction box. The posterior, it is in the posterior cranial fossa. Cranial fossa. All structures, all fibers, motor, sensory, all the things will come into one small area called junction box. Just like our electrical system in the house, we have a junction box outside. So that is a brainstem. Brainstem, it controls all the functions, literally all the functions of our body, sensory, motor, pathways, afferent and different. Some tracts go from spinal cord to brain, and some tracts come down from brain to spinal cord. They're leaving and entering the brain. Almost all nuclei of the cranial nerves are present in the brainstem. Brainstem consists of 3 parts: midbrain, pons, and medulla. Pons is the biggest part of all the 3. Actually, I wanted to show one. I'll show you one picture. I'll show you one video to you after at the end of this. Brainstem. So brainstem functions also are very important, and clinically, if you take the history of the exam patient, you can say that this patient is having problem in the brainstem. So that is the thing. And brainstem also harbors a cardiac center, a respiratory center, a vital center. If something happens to this, the patient may have cardiac irregularity and breathing difficulty. Respiratory arrest also can happen. And the brainstem controls your consciousness, your alertness, your arousal. And this brainstem anatomy is precisely organized. It is very, very, if you really take the cut section, see each tract, you can separately see and visualize. And sometimes only one tract may be, sometimes half of the brainstem will be knocked out. Sometimes bilateral brainstem can get involved. So it depends on the condition. For example, if patient has a hemiparesis and only third nerve is palsy, there is a lateral rectus palsy, the eye movements are involved. So you can say that this patient has a brainstem stroke. This is called Weber syndrome. So this is the beauty of neurology. You can, like mathematics, you can localize the lesion very promptly. Then coming to after the brainstem, you have spinal cord, which is the root for all communication between brain and the extracranial structures. This brain and extracranial. That's why this part is called brainstem. Brain and spinal cord. Spinal cord ends at T1 and then phylum like root. If you think brain as a tree and spinal cord, phylum terminal as a root, this is brainstem, rightly named as a brainstem, the small bit brainstem. So spinal cord is the root for all communication between brain and the extracranial structures. It has all afferent and different fibers. They are grouped and into a tract. We call it a tract: spinothalamic, robothalamic, corticospinal. There's so many tracts are there. If you take a spinal cord section, different level, you will understand. You must have read in anatomy. You may also get a question of spinal cord section as a short note. So this is all about the spinal cord, and each tract will decussate into opposite side at different levels. You should be able to know. Therefore, you will know if a particular area of spinal cord is damaged. Say, for example, transverse myelitis. Transverse myelitis, the one which is decussating will have lesions, will have the signs on the opposite side. The one which is not decussating, coming straight, will have signs and symptoms on the same side. So this is the beauty. This is a cross features will be there. The dissociated anesthesia and all the stuff we will say.